Hey, everybody. Welcome back to Pulm Peeps. We are very excited to be back again today with another episode in our guideline series about asthma. And today, I think, is one of the most interesting topics, one of the ones that comes up the most for our pulmonary fellows and certainly for our patients, which is the use of biologic therapy for asthma patients, really a game-changing paradigm shift in therapies. Christina, you are podcasting live from Cabo right now. How are you? How's the vacation?
Doing great I know. I think I'm going to put a plug in for, you should do like a live Pulm Peeps podcast next time in Cabo. Our summer tropical, but really excited to be here. As you mentioned, this is such a big area with biologics for severe asthma treatment, not only for our patients, but really for our trainees. I know our fellows will be joined by Polly and Tom a little bit later today in the show as well. But such an area that I think people want to understand more, and really excited to have a guest today who is an expert in this area. So with that, I'm going to go ahead and introduce our guest for today, who is Dr. Megan Conroy. Megan completed her fellowship training at the Ohio State University, where she is currently an assistant professor of medicine and is also the associate program director for curriculum and quality in the PCCM fellowship there. Megan's clinical area of expertise involves asthma and biologic therapies, and she was recently recognized for her work in this area as a 2024 Chest Airway Disorders Network Rising Star. Such an honor to have you on the show today, Megan.
Thanks so much, Christina. I'm excited to be here and looking forward to our discussion on this today.
Yeah, thanks, Megan. Really appreciate it. I also wanted to make one point that you pointed out to us, and actually a couple other people have mentioned as well, is that this has been our guideline series initiative. We really want to help fellows, residents, faculty understand what the core recommendations are for different disease processes. But you pointed out that there is an important distinction between what GINA does or what GOLD does and what like a true guidelines do. In that guidelines have a real set of criteria. They have to use narrow PICO questions to provide the guidance, where GINA is giving a more sweeping guideline or a report on how we should manage asthma and severe asthma. And so it has a little bit more flexibility in that, which makes it a really helpful tool, but just a thing to point out for our listeners. And with that, we will welcome back our fellows who are leading this series. They've been unbelievably dedicated and successful at this thus far. But Polly and Tom from Johns Hopkins joining us again. Welcome back to the show.
Thanks, Dave. Excited to be here and back delving into this topic that, as Monty mentioned, is near and dear to our hearts in our everyday clinical practice. So can't wait for the discussion.
Good morning, everyone. Happy to be here.
Awesome. And so with that, we will dive in. First, our standard disclaimer. We are going to be talking about a bunch of different medical topics. None of the things we discuss are for specific medical advice in a specific case. The opinions we discuss may not reflect those of our employers. And if we talk about patients, the patients will either be fictionalized or they will have had data changed to protect their identity. For today, the roadmap is going to be that we're going to cover the definition of biologic therapies. We're going to talk about which patients are suited for this or which patients have this as an indication. We'll talk about the different types of biologic therapies that are available for asthma treatment, how to choose the right one, and then the real world impact of these therapies using the GINA guidelines as a frame of reference for all of this. So Rupali, hopefully you can start us off with a case.
Sure, Dave. So I had a patient come to clinic. She's a 27-year-old woman who came to establish care with me in clinic with a history of multiple hospitalizations for exacerbations in the past year. She had fortunately gotten lab work done before she came to see me, and her lab showed that she had elevated peripheral eosinophils at 500, high IgE levels in the hundreds as well, and a positive allergic RAS panel for cats, dogs, and various pollens, suggesting she was sensitized to some of these allergens. She at that time was on a daily low-dose inhaled corticosteroid with a long-acting beta agonist, but was still struggling to control her symptoms. She was also reporting to me that she had frequent bouts of what sounded like sinusitis, requiring some antibiotic courses in the past. We discussed a few things at that visit, minimizing her exposures to these allergens. We up-titrated her to a medium-dose SMART, or single maintenance and reliever therapy, with her ICS LABA during this visit, and we also started a leukotriene antagonist to see if that might help. I additionally sent her to the ear, nose, and throat specialist to further explore her sinusitis and possibly evaluate whether she could have any comorbid conditions like nasal polyps. Given her persistent symptoms and her type 2 inflammation per her phenotyping, I started thinking about a biologic targeting some of those type 2 pathways that might be the next step in breaking this cycle of exacerbation. Megan, based on that case, when do you typically start thinking about biologics for your patient?
Yeah, thanks for that summary, Rupali. I think that's the exact type of case and the right time to start thinking about these biologics ahead of pulling that trigger. And before talking really specifically about when we start the biologics, I'd actually like to point out several really important notes that you made there in your approach to this patient before starting a biologic. Particularly, you started to explore some of the allergic sensitization and considered some ways to maybe mitigate her exposures. You also thought about other cofactors like her chronic rhinosinusitis and worked to control those symptoms. And I agree, I'll also engage a multidisciplinary team like otolaryngologists and allergists when I've got these complex cases that are difficult to control. One really key aspect that I think we take for granted, both in our clinical case discussions and our real world care, so it's worth calling it out, is the very simple but very important nature of assessing our inhaler technique for our patients. And this really comes back and brings us back to a key distinction between difficult to control asthma and severe asthma, because not all difficult to control asthma is truly severe. So some estimates suggest that probably about 20% of patients with asthma are difficult to control, but only about 5% of patients with asthma have severe asthma. So what's really happening in that other 15%? Most commonly, that's the impact of other uncontrolled cofactors like gastroesophageal reflux, chronic sinusitis, nasal polyps, untreated sleep apnea, postnasal drip, smoking, anything, vaping, THC, cigarettes, frequent allergen exposures, and other cofactors that can drive poor asthma control. And when we address these other entities, a lot of times the asthma comes under control. And also in that 15%, that difference between 20% difficult to control and only 5% of being severe are patients who aren't taking their inhalers correctly or as often as they should. So while seemingly simple, not these complex biologic drugs, it takes time and intention, and importantly, knowledge of how to use these inhaler devices to be able to teach our patients to use them and to check in over time. Just like anything else you learn in fellowship and beyond, our knowledge can degrade over time. And so I recommend continually reassessing how your patients are taking their inhalers to make sure that what you have prescribed is actually getting into their airways. I joke with my patients, like I give you a pill, you swallow it. I'm pretty sure it's in your body, but it's not the same with inhalers because these are hard medications to take. And so it's an important point to note and an important aspect in the assessment of whether or not a patient has severe asthma, because all the medical decision-making you describe, Rupali, totally appropriate. And the last key is delivering that medicine into the patient. So I'll come to biologic therapy in patients who really, despite optimizing all of the comorbidities that can impact their asthma control and ensuring that they're getting and taking their combination controller inhalers correctly through that stepwise care, who continue to have poor asthma control as evidenced by at least 2 exacerbations in 1 year requiring oral corticosteroids, or any patient who requires daily oral corticosteroids to control their asthma. Now, thankfully, these biologics are quite effective medications, but they're also costly. They're not entirely without side effects. And we don't really have clearly defined off-ramps of stopping these medications after we start using them. So it is prudent to ensure that you've got holistic care alongside your step-ups in care towards biologics, because it's important to know that really not all of those 20% of patients with difficult to control asthma should be on biologic therapy.
Thanks, Megan. That was so wonderful to walk through, and Rupali, such a great case to bring up as well. I think a lot of those listening today probably have the opportunity to take care of a patient very similar to the patient that you cared for in clinic. And Megan, yeah, thank you for bringing up such an important point, right? It's a basic point, as you mentioned, but so important is what are our patients actually taking, right? Are they getting their medications filled on time? Are they actually taking them? As you said, you can assess, can they swallow the pill, but are they actually getting the inhaler technique down right? And are they actually getting the medication delivered to where it needs to be? And such an important thing to do, I think, both in the clinic and in the inpatient setting. I was recently on service and we had a patient who got a new type of inhaler prescribed to her, which was on our pharmacy formulary. And I'll say that the entire team had some difficulties in trying to figure out how to use the inhaler correctly for her. It was like the clicking and the coordination was really difficult. It was like, I even struggled with it a bit. So I was like, I can understand how this is really happening in the real world. Fortunately, we were able to get it fixed for her, and we did some great teaching that we all benefited from, but such an important topic to think about. And I want to even take a step back, really looking forward to all of the things that you were mentioning, Megan, that we'll get to during this episode. But taking a step back and talking and reminding ourselves about this type 2 inflammatory pathway or phenotype. And we brought this up in our first asthma series a few weeks ago. And you may have remembered we talk about some of that for type 2 inflammation. Some of the key players were eosinophils. Biomarkers could be high eosinophils as well as high fractional exhaled nitric oxide. Trigger types were allergens. Steroid responsiveness, we said, is usually high in this phenotype, and treatment included inhaled corticosteroids. And then we briefly brought up biologics and previewed this episode when we talked about that. But unlike bronchodilators or systemic corticosteroids, biologics target key immune system components, which really are so great and fantastic, though, because they can offer additional therapeutics for patients whose asthma has been difficult to control. And Tom, I'd love if you can walk us through a little bit more so listeners today can understand the type 2 inflammation pathway.
Yeah, absolutely. Thinking about these different inflammatory mediators is a little bit of a throwback to immunology from medical school with the reappearance of cytokines and interleukins and things of that sort. And we can think of these biologics as blocking key players in this type 2 inflammatory cascade. There's actually a lot of really great review articles that you could just do a quick Google search for that have nice pictures of where these different biologics target. The key ones that we're thinking about with our biologic therapies are IgE, which is involved in the allergic response as well as mast cell activation, IL-5, which is involved in the production and survival of the eosinophils, IL-4 and IL-13. These contribute to airway hyperresponsiveness, mucus production, and can potentiate IgE synthesis. And then also much higher up the pathway is a molecule called TSLP. This is an upstream pathway that affects multiple downstream pathways and plays an important role in some of our different types of biologics.
Thanks, Tom, for walking us through that and giving us a little reminder of some of the pathways we discussed. And we'll make sure that we share some images with folks so they have a good reference. Now that we understand the targets, I want to make sure that we talk through the biologics systematically about when we're going to be thinking about them, about how they work, and how we can apply them for our patients. And so to do this, kind of want to set the stage. Megan brought up some great points that difficult to control asthma and severe asthma have different definitions. They're not exactly the same. And so, Rupali, I was hoping you could tell us what GINA says about how we should be thinking about our patients for who should be on biologic therapy and when we should be considering them.
Yeah, thanks, Dave. According to the GINA Guide 2024, biologics should be considered for patients with severe asthma who meet a few different criteria. So one, they remain uncontrolled, their asthma, despite high dose inhaled corticosteroids combined with long-acting beta agonist. Two, these patients have frequent exacerbations that, like Megan mentioned, require systemic steroids or hospitalizations. And three, there shows some evidence of type 2 inflammation, as we've been talking about. This includes elevated eosinophils. 150 is often the lower threshold for cutoff. Increased fractional exhaled nitric oxide, like we discussed in our previous episodes, or asthma symptoms that seem to be allergen driven. So in summary, we should be thinking about using biologics in patients with severe uncontrolled asthma, despite being optimized on medium or high dose ICS LABA treatment with usually more than 1 to 2 exacerbations, in whom we see clear markers of type 2 inflammation. The GINA Guide also highlights the importance of intervening early with these biologics, because in the long run, they can help minimize steroid exposure and actually optimize long-term lung function decline and prevent that from happening. So according to the GINA Guide 2024, think about biologics in that subset of patients who maybe meet those 3 criteria after, as Megan had mentioned, we ensure that they're using their inhalers correctly and are actually getting the medicines that are prescribed to them.
Awesome. Thanks so much, Rupali. A great framework for the rest of our show today. And I think really turning to try to understand almost like a matching pair now, right? Which biologic, what does it target, and which patient population is this going to be best suited for? And so glad to have Megan on. Megan and I have the opportunity to work together on the CHEST T&T committee. And in Boston, Megan actually had the brainchild to one of the live questions for the CHEST challenge was actually matching biologics with their target pathway as well as indication. So for those listening today, we won't reuse it as a question for CHEST 2025, but just anything in pulmonary critical care medicine can be used for patients in real world as well as for CHEST challenge and medical trivia. But Megan, based off of that, tell us a little bit more DA approved biologic therapies that are available currently.
Yeah, sure. So the first longest standing approved biologic is omalizumab. This is known under the brand name of Xolair, and this is an anti-IgE monoclonal antibody. And this is approved for use in allergic asthma, among other indications. Next on the scene is mepolizumab, known under the brand name of Nucala. This is for use in eosinophilic asthma and is an anti-IL-5 monoclonal antibody. There's also an IV medication. It's less frequently used because it's IV and not subcutaneous, called reslizumab. This is under the brand name Syncare. And this is also for use in eosinophilic asthma as an anti-IL-5. Benralizumab, known under the brand name of Fasenra, is an anti-IL-5 receptor monoclonal antibody, also for use in eosinophilic asthma. Dupilumab, known under the brand name of Dupixent, targets the IL-4 receptor alpha subunit, which is a receptor subunit also shared by IL-13. So it targets both IL-4 and IL-13 by targeting that alpha subunit. And that's approved for use in eosinophilic and allergic asthma, among other indications. Also recently in October 2024, got an indication for use in COPD with eosinophilia. So dupilumab with use not just in asthma in the pulmonary world. And then newest on the scene as of 2021 is tezepelumab, which is known under the brand name of Tezspire. And this is an anti-TSLP, or that thymic stromal lymphopoietin upstream mediator that is for use in both T2 high asthma and can be used in T2 low asthma phenotypes. And this is the first and only drug that we can use there.
Thanks, Megan, for walking us through that. And also, just a disclaimer to our listeners, you don't have to be an expert at pronouncing all these names to be an expert pulmonologist. So, and no pressure there. Megan, I was hoping you could help us with the link between phenotyping and picking a biologic. I love that in pulmonary and critical care medicine, we're moving a lot more towards phenotyping, personalized medicine. I think these medications are an indication of that, especially when we're using them, like as you mentioned, dupilumab and COPD now, when we have an eosinophil component. But when you're talking to a patient, how much are you focusing on the target pathway, measuring biologic measures of that target pathway versus other clinical factors that you gather from examining and talking to the patient to pick the right drug?
Yeah, absolutely. I think it's really a combination of the both. It's a difficult task if we say pick the one best biologic for any given patient in front of you. It's a trick question. There may not be only one. And in general, I would say that I really will approach choice for a patient both by considering all of the totality of data of what do I have to say is the predominant driving inflammatory pathway in this patient, which also involves knowing other comorbidities that are big factors for this patient. So if they have other comorbidities that might be impacted by a biologic, I conceptualize this as another area of evidence of the systemic manifestations of that inflammatory pathway. So patients who have concomitant food allergies, IgE-mediated food allergies, may be a predominant allergic phenotype. Those who have chronic rhinosinusitis and nasal polyposis may have good effects from IL-5 or IL-4 targets. For eczema, really with the IL-4 target, and it's same for eosinophilic esophagitis. These are entities that some of these drugs carry independent FDA labeling for. So our dermatology colleagues and our GI colleagues and our ENT colleagues are prescribing these for those indications. And if you've got a patient with severe asthma and some of these other diseases, it seems to me that's probably helpful in establishing a more confident inflammatory endotyping for that patient. That's really kind of the question we're getting at when we say pick which biologic is best, is what pathway do you think predominates in driving this patient's asthma? So As some concrete examples, I might choose omalizumab, not just for a patient whose total IgE is high and who I find sensitization to a perennial arrow allergen. So that's the biomarker data. But really in that patient whose asthma by clinical history is truly driven by exposure to these sensitized antigens. Other factors that should play a role are things like whether or not a patient is on chronic oral corticosteroids. This is maybe one of the most important things to play into a decision to choose a drug that has evidence to assist in reducing oral corticosteroid dosing, which we have in dupilumab, mepolizumab, benralizumab, and omalizumab, but tezepelumab does not have evidence to reduce oral corticosteroid use. And so for many patients, several of these biologics could be a reasonable choice. And without any head-to-head randomized controlled trials, there is very low certainty of evidence to definitively guide you one way or another. To reframe this difficulty, I'll say there are really multiple reasonable choices. And if at first you don't succeed, you have additional options that you can try as a second line, which compared to 20 years ago is a really exciting space to be in severe asthma. And quite honestly, is a part of why I do this work.
Thanks, Megan. That was fantastic and a great way for us to think how to match a patient's certain phenotype with a biologic. So just to summarize, once we know a patient has severe asthma, an optimal treatment with evidence of type 2 inflammation, the next step is really to choose the right biologic. The GINA guide does give some specific indicators for some of these biologics, which lends to patients qualifying for these drugs, which, as you mentioned, is part of choosing the right biologic as well. So omalizumab, as you mentioned, for allergic asthma with high IgE levels ranging from 30 to 700, affecting dosing. For the IL-5 blockers that you mentioned, the mepolizumab, bresilizumab, benralizumab, for the eosinophilic asthma with different cutoffs of EO cutoffs that range from 150 to 400, depending on which drug is chosen. Dupilumab, when there's eosinophilic asthma with comorbidities, like you had mentioned, nasal polyps, eosinophilic esophagitis, atopic dermatitis. And then, as we mentioned, is a tezepelumab for broader severe asthma, even when the biomarker thresholds aren't met, can potentially be prescribed in that setting. So, Megan, I know we've gone over all of the FDA-approved biologics at this time. We went over what the GINA guide recommends in your day-to-day practice, but are there situations when even these strict categories are not something that you abide by and when you have to think outside of them? And how do you think about navigating the biologic selection a little bit more?
Yeah, and really these categories that are described in the GINA guide derive from the FDA approval for these medications, which is, of course, from the inclusion criteria in the randomized trials that prove their utility for use. And not really deviating strongly from any of these categories, right? Because this is the area in which they are proven to use the patients that you're predicting to have the best response for. But really, as mentioned before, there may be multiple reasonable options for a patient. They might fall into a couple of these strict categories. And really, when that happens, I think choosing between them, it really may be subtle aspects that push you one way or another, necessarily deviating deeply outside of these categories. But I think probably the biggest example where you might be pushed outside of that, unfortunately, there's some examples of insurance formularies pushing you out. So certain systems that you work in might say you have to try omalizumab first before you can try a second drug. If the patient doesn't fit criteria for allergic asthma with an IgE and a weight within dosing, don't do it, right? It doesn't make sense to deviate based on an insurance formulary or insurance guidance for a patient that's not going to respond to this medication there. One nice thing that the GINA guide does, not only in these categories, they also give some nice algorithms that try to overlay some of the factors that might predict better response to a drug. So things like a higher pheno, higher absolute eosinophil counts. And again, this really comes to evidence of strong endotyping. That is the predominant inflammatory pathway driving asthma for those patients. So it makes sense that if you're more deeply within that, you have higher levels in that inflammation, you're going to respond a little bit better. And so it can make it still clear as mud, but sometimes it can give you some of the nuance to push one way or another.
Thanks so much, Megan. Yeah, I think such an important point, as you said, right? Looking at the patient in front of us, and sometimes we can have restrictions, as you said, based off of insurance, but really trying to make the best decision that we think for our patient, and really comes down to, I know, a shared decision making. I think one of the things that we're hoping to do today is help those listening today really understand kind of practical implications of choosing the biologic for someone. And one of that we haven't really discussed yet, but hoping you could get into more is really this dosing frequency as well as route of administration. I know the majority are subcutaneously administered, but one intravenously, which I know can really make a big difference in real world use. So hoping that you can walk us through a little bit more on how you think about that and how you start to talk about this with your patients, as well as, sorry, I'm going to repeat that sentence. Hoping, Megan, that you can talk to us a little bit more about how you incorporate this route of administration as well as frequency with your patients when you're talking with them in clinic.
Yeah, absolutely. First, I'd say route of administration is a big driver in my practice, the subcutaneous versus intravenous. My practice is honestly 100% on the subcutaneous administration. I don't know that I've ever prescribed reslizumab as the IV version. And that's really because of ease of use. Since the pandemic, these subcutaneous medications, we can use all of them now by self-administration at home. And overall, that is the route that my patients prefer because it's just so much easier. In our clinic, we've got protocols for patients to get their first 1 to 3 doses in the clinic with a nurse. We partner with clinical pharmacists to get them more medication training. And then the patients are able to take this at home and they do really well managing it on their own. Pragmatically, sometimes there's reason to administer it in a healthcare facility. So things like infusion centers. And this comes down honestly to insurance or strong patient preference. If you deliver it in an infusion center, oftentimes that's processed through medical benefits compared to a home administration is processed through pharmacy benefits. So when we talk about disparities in access, sometimes if someone has limited pharmacy benefits, but good medical benefits, this can be the difference between whether or not they can get access to the medication. And so exploring both venues can be helpful. Frequency of administration does come up. We can span every 2 weeks to every 8 weeks at longest between these medications. And when you're able to give it at home, every 2 weeks may not be that big of a deal if you're not needing to drive or come into a healthcare facility. But maybe for needle phobic patients, so patients on the younger end, perhaps, who are maybe just transitioning from pediatric care, I experience might have a little bit more needle phobia. Or some patients whose job or lifestyle takes them traveling away from home frequently. Longer time between administrations may make it more feasible to use these medications because they require refrigeration and it's not like and they're delivered on a monthly basis usually. If you're traveling for 4 weeks at a time, it can be very difficult to get properly store and take those medications, say people who are working internationally or traveling internationally in retirement. So sometimes working with patients on the frequency and the route of administration there, be at home or an infusion center, it really needs to personalize to be able to fit into their life.
That's great. Thanks for going over all those, Megan. And I think it really shows us how we can personalize. There's so many options out there now, fortunately, and different routes and timing that we can personalize our care. Just to summarize for our listeners, a quick rundown of the different dosing we're talking about here for these drugs. Omalizumab, this is dosed every 2 to 4 weeks, making sure that you're paying attention to the patient's weight and their IgE levels because the dosing is dependent upon those. Mepolizumab is dosed every 4 weeks as a subcutaneous administration. Ryzluzumab is every 4 weeks, and that's the IV formulation that we've mentioned. Benralizumab is every 4 weeks initially, and then is spaced out to every 8 weeks. Dupilumab is every 2 weeks, and tezepelumab is every 4 weeks. It's definitely part of the shared decision-making conversation. These schedules of these different drugs can be tailored to meet the patient's preferences, what their logistics are with both coming to clinic and with their insurance, and ultimately trying our best to ensure adherence and the efficacy of these medications.
Great. Thanks, Tom and Megan, for talking to us through some of the practicalities, some of the dosing schedule, some of the considerations for our patients, and how we're going to actually use them. Megan, like you mentioned, the needle phobic. I always have this story of one patient who came to me and hadn't started her biologic because she was so nervous about doing the sub-Q injection. And then we did her first one observed and she was like, oh my goodness, that was it. And this was totally nothing. And then she responded very well. So Megan, one of the themes of the conversation we've had is that there are multiple right answers in this case. Sometimes when you have a patient who has severe asthma for biologic, which is nice, gives us a lot of flexibility. But that also can be difficult for people who are just starting out, who are like learning how to choose which drug.
So what do you do for a patient that meets criteria for multiple of these drugs? Say they have both elevated IgE and an elevated eosinophil level to target. How do you prioritize between these things? Is your choice end up being driven more by the biomarker level, by the patient's symptoms or comorbidities, or by their preference? How do you go through that?
So I'd say it's really a combination of biomarkers and clinical history. As for preferences, it's kind of rare for my patients to come in with preformed preferences on these medications. And so while it's definitely a conversation, definitely an example of where I think providing a recommendation to the patient is key. So for the type of patient you described where they have both IgE and eosinophils, they may honestly be a candidate for any of the available biologics by FDA labeling. Then it comes to history combined with those biomarkers. So running through some scenarios that might push me one way or another. I might choose omalizumab in a patient here where both clinical history is really predominantly one of exposure to that sensitized allergen, resulting in worsening of symptoms. So thinking of a patient example of someone who, say their family got a dog and asthma control went off the rails thereafter. Immunotherapy might play a role here. If no improvement with that, or even concurrently, I would start Xolair then. And in this scenario, you can have a really great response. And I've got patients who can even be around their dogs then. Certainly an ideal scenario would be mitigating and not having a dog, but this is what happens in real life. In a patient who has some sensitizations that aren't clear by history to really be a driver of their asthma symptoms, maybe they've got some mild IgE elevation and they've got an absolute eosinophil count that's maybe borderline for considering it to be an eosinophil driver, say maybe at that 150, or sometimes you check it and it's below that. That's a patient where I might lean towards tezepelumab. So here I'm describing several sort of borderline phenotyping where it's not, I don't feel confident that this is T2 high inflammation driven. Maybe polygranulocytic or neutrophilic drivers as well, but I can't quantify those by biomarkers as easily in clinical practice. Even T2 high patients do really well with targeting TSLP. And that's why the GINA guidelines suggest that with higher ENO and higher eosinophils, they'll predict a better response to tezepelumab, because that's true. But you'll also see adequate response in patients with T2 low. So take another patient, say they've got a variety of allergic sensitizations and confident eosinophilia. They're on repeated checks closer to or over that 300 absolute eosinophil count. That's a patient where I'd likely lean towards dupilumab because this targets both eosinophilic and allergic pathways. Say this is a patient who also has nasal polyps or who I have suspicion for aspirin exacerbated respiratory disease. Those subsets of patients do really well on dupilumab. So in combining biomarkers and the clinical history, it really comes to more help confidently categorize patients. And if they appear to be T2 high and it's predominantly allergic or predominantly eosinophilic, that might drive you to choose your target. If they got a little bit of everything or they're clearly T2 low, that might push you towards TSLP. And no matter what you choose, it's really recommended that you give a 4 to 6 month trial of these medications once you start it before you call failure or success. And so what do we call success in these scenarios? And really and it's helpful in setting expectations with patients on this too. What I'm looking for is a 50% reduction in flares or a 50% reduction in oral corticosteroid use in a daily fashion. A cherry on top that I'm always hoping for is improved daily control, improved lung function, or improved asthma-related quality of life. But you can't promise this universally. So this is not our first test of success. But when we land on the right drug, if we start it early, particularly in patients with shorter disease duration, who have lower BMI, who are not in the most extremes of disease severity, we've got a good chance of actually seeing clinical remission of asthma symptoms while still on treatment. And database analysis suggests in about 20% of patients, we can get to that sort of clinical remission on treatment in asthma with these drugs. So it's really exciting to respond. And also an argument that maybe if you're not getting the right one first, might be reasonable to keep trying.
That was so awesome, Megan. Thank you for going through with that. And I think one of my key takeaways so far is what you just mentioned, where you actually said recommending to have a 4 to 6 month trial before you can define success or failure. I know we've been consulted by teams and like an inpatient has been on biologic for a month and they're not necessarily having any improvement. Which one should we switch to next? And it's not like they need more time. So I think that, thank you so much for mentioning that, and really liked how you also added other things that Mark
success with 50% reduction in flare or 50% reduction in oral corticosteroid use. So that was fantastic. And thank you for bringing that up. And I think what we've said so far was biologic can depend on a few different things, but three things that we've mentioned so far throughout the show today are really the patient's asthma phenotype, biomarker levels such as EOs, IgE, as well as allergic testing and associated comorbidities. And GINA 2024 recommends matching the biologic to the specific patient. And Rupali, I know you and Tom know it's hard for me to remember things sometimes, but you try to bring up new tools that can help you remember some of this. And obviously we'll post a fantastic infographic that you and Tom have worked on really hard. But Rupali, walk us through a way that you like to remember some of the biologics and take us back to your patient's case.
Definitely, Monty. Thank you so much. And thank you, Megan, again for that fantastic summary. As Monty mentioned, we will have an infographic linked to this episode with all the information we provided here. So we don't, for those of you who have a hard time memorizing all this information, it will be there laid out for us simply. Monty, we can refer to it when we need it. But if we'd like an even simpler memory tool, something I reach for in the clinic, just when I'm trying to quickly think of patients and biologic preferences as well as what they may qualify for. Here's the little memory device that I use. So it's a little rhyme. So OMA avoids allergies, MEPO mutes, Resley reduces, and Benra blast EOs, DUPI destroys stuffy polyps and swallowing EOE, and TEZI tackles tough asthma for all. So that's just a quick way to help you remember some of the indications as well as what the drugs might be used for and how patients can qualify for those drugs. Because as Megan mentioned, the qualifications are often based on the clinical trial inclusion criteria, and that is very nicely laid out in our infographic as well. So just getting back to my patient's case for a moment. And my patient's case, the ear, nose, throat doctor reached out to me and let me know that in clinic, they had been able to scope my patient and she had severe nasal polyposis that was discovered. So in this scenario, she had already been on oral corticosteroids for some time. So we chose together to start her on Dupixent and then plan to bring her back to clinic to monitor both her asthma symptoms as well as her sinusitis symptoms thereafter. So it was a really nice case of multidisciplinary care and working together to get her started on the right biologic for her.
Rupali, you're the queen of mnemonics. I feel like your mnemonics are ranged far and wide and always really helpful. So thanks for sharing that one. So you mentioned something there is that you brought this patient back to clinic to monitor. Obviously, we're going to be watching these patients closely. And in our first two episodes, we did talk a lot about how important reassessment is in the therapy of asthma patients. So Megan, hopefully you can help us again of what type of monitoring we're doing with these patients. What are we looking for when they come back to clinic? Are we checking any lab levels? Are checking PFTs or symptoms? What should we be looking at?
Yeah, absolutely. So anytime that we're starting a biologic, as noted, you want to give a 4 to 6 month trial to really monitor response. The primary outcome in the randomized trials that put these medications into practice was a reduction in annualized exacerbations. So it takes a while to see that effect by not having exacerbations, right? So I generally will recommend seeing a patient back within about 3 months of starting that biologic. You want to assess for side effects, check on initial benefits. You may trend their asthma control scores, make sure that they're doing okay with the medication, not having any other surprises. You'll want to follow them really still at that 4 to 6 month time frame then to really check on their response. And again, I'd categorize success for a biologic in seeing that 50% reduction in exacerbations or 50% reduction in daily steroids. And anything short of that, think of as suboptimal. So if we're still at that at about the 6 month period of time and not reaching those, you might consider changing to another drug. And really how they responded to one drug can become helpful data point in what you would choose second. As for monitoring, beyond clinical monitoring, for these specialty medications, considering that they are specialty medications, there's actually very little that we need to be following. Within those first 6 months, I would recommend repeating spirometry. Many of these drugs have evidence of improvement of FEV1, often around 140 milliliters. While this is not a patient-centered outcome or a way that I would solely validate use of the biologics, it can be a nice objective metric and one that insurances can take as a rationale to continue paying for the therapies. For omalizumab, you need to be sure that your patient has an up-to-date epinephrine auto-injector because omalizumab has a black box warning for anaphylaxis. This is relatively rare, and especially if they've tolerated their first 3 doses in clinic, they're likely to do very well at home, but it is important to make sure they have that up to date. For dupilumab, you are going to want to monitor eosinophil levels, particularly within the first 16 weeks of therapy. And for patients who start at a higher eosinophil level at baseline, particularly like around 600, because there are rare hypereosinophilic syndromes that can come up as a reaction to this medication that might necessitate stopping or consider using one of those anti-IL-5s to obliterate some of those eosinophils if that happens. For any patient who's on oral corticosteroids and you're tapering those doses because of their response to biologics, that's another space in which you're going to need to have close clinical monitoring to avoid abrupt withdrawal and look for adrenal insufficiency. Otherwise, you don't really need to follow a lot of biomarkers with these biologics because it's not going to change your management. You're really looking for clinical response and looking for the opportunity to down titrate other controller medications, trying to avoid long-term risks of side effects from some of those medications.
Megan, can I ask you a follow-up for that dupilumab question?
Mm-hmm.
I know you have to monitor for these hypereosinophilic. What should you expect to see for patients in those first 16 weeks? Should eosinophils go up at first and then down? Like what trends are normal and then what trends are concerning aside from eosinophils just skyrocketing?
Yeah, after starting dupilumab, you might see a slight increase in eosinophils. So say somebody starts out at 300 and they go to 400 or 450, like that's not a concerning level. But if you have a patient whose eosinophils come up to over 1500, I think the highest I've seen is 4500, that is definitely out of the ordinary. You're, of course, going to want to look for additional causes of that eosinophilia, which you probably did before starting these medications, but certainly is concerning for a hypereosinophilic reaction. Oftentimes, when patients have those hypereosinophilic reactions, which again is rare, I haven't seen a ton of it, thankfully, they may actually have like clinical worsening as evidenced by systemic eosinophilic penetration there, as you do with hypereosinophilic syndromes with EGPA, that you see increased clinical manifestations in line with those increased eosinophils. Particularly if you start dupilumab and a patient saying, I'm doing worse, really make sure you're checking those eosinophils.
Thanks so much for sharing, Megan. And I anticipate several of our fellows will probably just have this last section like on repeat in fellows clinic when we're thinking about which biologic to choose and things that we should be thinking about. And I think a purpose of today, we wanted to just highlight biologics based off the GINA 2024 guide and really showing steroid sparing strategies and how biologics play a central role in this. And we've been talking about how they can be so transformative for many of the patients that we get to care for. But I know that there's also some challenges in being able to have biologics prescribed for all patients. And Tom, I know you ran into some of these issues in your clinic recently and hoping you could share a little bit more about that with us today.
Yeah, thanks, Christina. Definitely. I've realized just in the time I've been in Pulmonary Fellows Clinic that we really do run into cost and access as significant barriers to prescribing some of these. As Megan alluded to earlier, insurance can sometimes limit the coverage for many of these different medications. There are fortunately some patient assistance programs that can help. And GINA 2024 really emphasizes the need for equitable access to these biologics globally, particularly because severe asthma disproportionately affects underserved populations. So it's something we really need to work hard on and think about.
Yeah, thanks, Tom and Megan, for all that great, useful information and how we can actually be approaching our patients in clinic. Just to get back to our case, based on what Megan had recommended, my patient was able to return to clinic 3 months and 6 months after starting the Dupixent, feeling much improved. She reported no exacerbations, no need for oral corticosteroids. Her EOs we had measured, they were stable. There was importantly no evidence of hypereosinophilic syndrome. And we were actually able at that point to down titrate her inhaled corticosteroid because she was feeling better on the biologic. However, at that visit, she did share with me that she was newly pregnant. Now, Megan, I know it's clear that we've made huge strides with type 2 targeted biologics, but I want to ask you about a few special patient populations. The first is pregnant patients, and the second is patients who may not fit the typical type 2 asthma phenotype. We know there have been some newer publications and applications of these biologics in these populations. Could you just share with us your insights and your approach to consideration of biologic therapy in these special patient populations?
Yeah, absolutely. And asthma control in pregnancy Certainly, maybe a whole episode in its own. As we experience across all parts of medicine, and unfortunately the same is true for biologics, pregnancy is an exclusion criteria to randomized controlled trials. And our pregnant patients are protected from research as opposed to being protected by research. And we unfortunately also have limited post-market data in a lot of these drugs. So omalizumab, which we've had since late 90s, early 2000s, has the most data in pregnancy. There's 2 larger observational studies. They include 188 and 250 women respectively, and concluded they found no evidence of increased risk for major congenital anomalies compared to women who were unexposed to omalizumab who have moderate to severe asthma. There are pregnancy registries that were enrolled for mepolizumab, benralizumab, and dupilumab, and they've closed to enrollment. While I haven't seen formal individual reports of those data, a recent study that reported over 1,500 events reported to a global pharmacovigilance database does suggest some differences in these biologics. First, with regards to spontaneous fetal death, suggested lower reports for benralizumab, and some more reports for dupilumab, omalizumab, and mepolizumab, though those 3 drugs did show lower reports for preterm birth, pregnancy, and delivery complications later in term. Still, there's a significant paucity of data in this space, and FDA guidance is that there's insufficient evidence to inform on drug-associated risks in pregnancy. There are animal studies, both in mice and monkeys, and a lot of these monkeys, they gave 9 times, 5 times the dose that we give in humans and found no evidence of fetal harm in those animal studies, which is reassuring, but still really a lack of clinical data in pregnancy in our patients. Tezepelumab is the newest drug on the market since 2021 and has not had a registry, so there's no data reported for that in pregnancy. So this is really a vacuum of clinical evidence. In that vacuum, there was an interesting position paper came out this year that reports expert consensus on the use of biologics in pregnancy. This was a modified Delphi study, and they had 141 panelists across 32 countries, and they came to some reassuring consensus here. So they agreed the importance of risk-benefit discussions with patients and shared decision-making when thinking about continuing biologics in pregnancy. They felt that biologics do not need to be stopped while patients are trying to conceive, and that these can be continued throughout pregnancy. They even went so far actually to have agreement that biologics can be initiated during pregnancy, as long as it's in line with national prescribing data, and particularly for patients with frequent exacerbations, so 4 or more in a 12-month period. And that kind of comes back to the risk and benefit, right? The risk of very poorly controlled asthma in pregnancy is pretty high. In patients who have asthma-related admissions to the hospital or the ICU or the presence of steroid side effects, they agreed there should be a lower threshold for starting biologics in pregnancy. Again, very high risk associated with those things. And that asthma biologics can both be initiated and continued while breastfeeding postpartum. Of note, among the consensus, there was no consensus on the use of tezepelumab during pregnancy and breastfeeding because of the complete lack of data for this, but there was consensus for the other available biologics. And personally, this fits my practice. I do think it prudent to discuss with any patient of childbearing age who you are starting on biologic therapy in shared decision-making to really emphasize the difficulty in this space of possible and unknown risks to fetus with the known benefits of asthma control in pregnancy. And so anytime I'm starting this in a person of childbearing age, I will kind of unsolicited bring this up as we are starting it. And that's actually gone well. One of my most severely uncontrolled patients that started this conversation with was very thankful down the line that we had discussed it at initiation because it came up later. And that patient felt confident in making her choice to continue her biologic through her pregnancy and carried to term and a healthy toddler growing now and can see really good outcomes. But again, these are case reports and individual anecdotes and not large levels of data. When we think about your second patient population, the sort of T2 low asthma, severe asthma patients, this is a really important gap that was met with the approval of tezepelumab. And this is really the only biologic that we can use in this patient population. And they can have really great responses. So it's been a nice hole to fill, but still only one choice. There are more biologics in the pipeline. The one that seems most on the cusp is depemokimab, and apologies on, again, showing the difficulty in pronouncing these things. This is an ultra long acting twice yearly anti-IL-5, and just saw that actually last month in March of 2025, this is under review in the FDA. So we may hear sometime soon that this may become another option. And when we think about a lot of these difficulties, right, these are spaces where we say there's not a whole lot of data. There's not a whole lot of data. And I can't count how many times I've already said it's hard to pick between these. And this is a guideline episode, right? So we've got ATS and ERS guidelines that came out in 2019, and 2019 was still on the cusp. There's been a lot of progress since that time. And in those guidelines, they say we should use anti-IgE, we should use anti-IL-5 and anti-IL-4 biologics for treating severe asthma in adults, but it doesn't give us guidance between them. The GINA guide provides some helpful frameworks, but we still arrive at multiple choices. And in an attempt to really provide some evidence-based guidelines to further assist in these biologic choices, the American College of Chest Physicians did convene an international panel of experts. And we've been working for the last few years to bring about the first guidelines for the use of biologics in asthma. While we are under our hopefully final revisions, I'm hopeful that these will be published within the year. And given that there's no head-to-head trials, unfortunately, this is very low certainty of evidence and really leads to only conditional recommendations. But I do think that this still fills a necessary vacuum of space with some necessary analysis and evidence to nudge between two options or to really validate a reasonable choice between two.
Thanks so much, Megan. And I know we're all looking forward to the release of those guidelines that you've been able to be a part of. And going back to something that you said earlier, definitely, I think we need to have an entire episode on asthma management in pregnancy. I think a common inpatient consult that our fellows get, and a lot of important things to really consider. And I feel like I don't want this show to end. I know that we've had such a great discussion over the last hour, and I feel like we can keep going. Before I head it to FERF, probably just one final thing, learning from today. I think you all have realized that there's more than one way to say a biologic name. But I think, Megan, one of the most important takeaways, as you said today, there can definitely be more than one biologic that's appropriate for a patient, but really understanding which pathway or phenotype predominates things. But I think with that, for such an informative discussion, but we'll hand it back to you to close out for today.
Yeah, what a great discussion episode. Thank you so much again, Megan, for coming on. Thank you, Tom Rupali, for steering this. And thank you all for listening. Join us for our next asthma episode will be a case review, trying to address some questions that we haven't talked about in our first three. But thank you all very much. This episode was written, produced, and edited by myself, Rupali Sood, Tom DiVentilio, and Christina Montemayor. And the audio is original music by Eric Rogers. And we'll see you next time.